Actually, topic for today is kind of a split thing. It's an introductory topic because the initial part for today was principle of tendon injury and repair, and hand injury is a separate topic which is to be taken later. So basically, the whole part of tendon injury, the whole chunk is in the hand. What we deal usually, all the tendon injuries we deal in the hand surgery. So this was just an introduction thing. I didn't know where to start. So it's not much of orthopedics actually. It's more of physiology and anatomy and the microanatomy of tendon because this has to be taken as a separate class. So, and then I've included also the surgical aspect later. That means the techniques of suturing and stuff, which is not pretty much a theory class. Actually, it should be taught in ORs whenever you come to surgical side. So yes, I'll be taking the second part, hand injury, in which we'll be dealing in much more detail with the tendon injury. So the whole thing I've taken from Journal of Bone and Joint Surgery, November 2006 issue. Basically, it's a review article which talks about all the tendon injuries and the surgical part of it. So just a crisp bit of it, not much. So just in bit detail about tendon structure. It's to a naked eye, it is a very brilliant white shiny structure, and it is a fibroelastic texture. Most of the times you can feel it like a band or a flat cord or a ribbon kind of structure if you palpate it. Okay, microarchitecturally same matrix and cellular elements, most of it is abundant type 2 collagen. And 19 to 95% of the cellular elements, they are all tenoblasts and tenocytes. So basically blasts and cytes, as you have myoblasts and myocytes, osteoblasts and osteocytes. So here you have precursor cell is tenoblast, you have tenocytes, and most of them are laid in longitudinal fashion along the length. So again, very less amount, 5 to 10% is chondrocyte or the on the bony attachment, specifically where you have epiphyseal attachment, tendo-epiphyseal attachment. There you can have little bit of chondroblast, synovial cells, and vascular cells. So this is a microarchitectural structure. Similar to a nerve, you have the core bundles, collagen bundles. You have epitenon, you have paratenon, and you have endotenon, as you have in a section of a nerve. So basically, the outer you keep going, the inner bundles, collagen fibrils, then you have collagen fibers, and you have a fascicle or a bundle. So these three are the microarchitectural subclasses. Basically, this are not visible to a naked eye. Then you have fascicle. Fascicle sometimes can be appreciated in bigger tendons such as quadriceps, tendo Achilles. You can see a fascicle with a naked eye, which is covered by endotenon. Then you have peritenon for a tertiary fiber bundle, and the whole tendon is covered by epitenon. So epitenon is the strongest connective tissue structure, which is basically providing a strength and rigidity to the tendon, whole tendon. Also, it has your lymphatics, vascular supply, and nerve supply to the whole tendon. The endotenon is a thick reticular network of connective tissue, basically separating each fiber, and paratenon is a loose areolar connective tissue, which facilitates in microarchitectural gliding of the tendon. So the beauty of tendon is, or if you carry a weight, if you need to do a work, there is a prolonged duration of, you have isometric as well as isotonic activity going on. So isometric activity, if you have prolonged isometric activity, your tendons basically are passing on the stress or the weight. So The beauty of the tendinous unit is they all adopted to the Krebs cycle, the anaerobic cycle, where you have majority of anaerobic cycle going on, so they can consume very less oxygen. The metabolic rate or the consumption rate of oxygen is at times 7.5 times lower than that of the skeletal muscle. So this helps in carrying load and performing the activities for longer periods. And if you have greater consumption and less production, then there will be ischemia, there will be necrosis. So since the mechanism is much more on the anaerobic side of energy generation, you don't really see ischemia and necrosis in a physiological healthy tendon. So the other side, flip side of it is you have a very delayed and low healing rate as compared to other tissue. So it's directly proportional to vascularity. If you have higher vascularity, structures such as face, muscles, all these heal very well, very rapidly because of the high vascularity. So the flip side here is tendons will heal very slowly post injury because of the low metabolic rate and low vascularity of it. So healing is again by intrinsic healing and extrinsic healing. So intrinsic healing is by the fibrovascular structures by your collagen, and extrinsic healing is because of the synovial thing which have some progenitor cells, chondrocytes, and your uh, tendon progenitor cells which will allow rapid healing. Yeah, so these are the phases for intrinsic healing. As any other normal tissue, you have inflammation first, which lasts for a week almost. It starts from third day and peaks onto, it starts immediately after 6 to 8 hours and peaks at 3 hours and can last for 5 to 7 days. So you have inflammatory phase here, then you have fibroblastic activity where you have raw collagen is deposited, then you have remodeling, which lasts for more than 28 days. Then blood supply, again, you have major sources, myotendinous junction, basically because it's a watershed area. You have muscle, which is highly vascular, and the tendon, which is relatively avascular. So myotendinous junction is the main supply. Around predominantly 70% of blood supply is through the myotendinous junction to the tendon. Then at the other end of the attachment, you have osteotendinous junction through the periosseal sleeve. Some blood supply is there, around 20-25%. And paratendon or the synovial sheath, where you have individual vessels running over the paratendon, provide around 10 to 15% of the blood supply. So accordingly, vascularity is compromised in particular area. Like myotendinous junction, as I said, has the major vascularity. So wherever there is a watershed area and you have the forces acting on it, so those areas are more prone to rupture. So cause of tendon injury, usually it can be acute or chronic and caused by intrinsic or extrinsic factor or a combination of it. Most of the time, acute scenario, trauma is the one where we see tendon ruptures or tendon injuries or lacerations or cut through. Or most of the times, extrinsic factors, you have, let's say, chronic ischemia in old age, osteoporosis, then you have many other medical conditions where you have tendon ruptures. Let's say use of ciprofloxacin, use of steroids, all these can lead to tendon weakening. So if you see physically, the kind of force you have, sudden acceleration or sudden deacceleration, neither of it. And most of the contact sports where you have these sudden acceleration, rugby, basketball, football, where you need to accelerate or deaccelerate suddenly, 90% of the cases has been related to ruptures, specifically in Achilles rupture, where your foot is planted strongly on the ground and then sudden acceleration, you need to plantarflex the foot. That leads to a avulsion injury of the Achilles tendon. Or at times where there is already pre-existing tendinopathy, you can have a midsubstance tear as well. Degenerative tendinopathy, is the underlying histopathological finding when you have a spontaneous tendon ruptures. That means any extrinsic force has not acted, person has been within their physiological limits of activity, they have had a tendon ruptures. That means just getting away up from the bed, climbing stairs, and during your routine activity, you had a tendon rupture. That is called a spontaneous tendon rupture. The rupture can be mid-substance or it can be from the avulsion from the bony attachment. Very rare musculotendinous attachment or degeneration, which is very rare because the vascularity is highest over there. So if you categorize the patients, you can have young age group patients where predominantly you will see apophyseal attachment, which is detached. Basically, the injury is at the apophyseal attachment. Why so? Because bones are still growing. So bones are soft. You have thick periosteums, periosteal sleeve, and at the apophysis there is a avulsion. So it detaches from the apophyseal attachment. If you see adults, you have at the musculotendinous junction because of the excessive muscle force of the pull. And if you go on the adolescent or later half of the age, osteoporotic side, you have mid-substance tear or you have at the insertion because of the degenerative changes happening or age-related changing happening. So whichever is the weakest area in that particular age group is going to be more prone for rupture. So you have these many predisposing factors, just to list them all. There's intrinsic factors. You can have evidence of previous injury, age is increasing, simply degenerative mechanism. Females are more prone for rupture because of the estrogenic predisposition. You have genetic predisposition in certain races. Muscle weakness, tendon microstructure as such. Some tendons are more prone to rupture. Quadriceps, tendon Achilles typically. You have obesity, diabetes, which are going to cause a metabolic alteration, and the quality of the tissue is going to be the poor because of the metabolic alteration. You have medications, fluoroquinolones, steroids. Then lower limb biomechanics is important one in the lower limb ruptures because of the sports or the contact injuries. You can have training errors, poor warm-up, footwear, and training surface. These are the extrinsic factors. So after rupture, we'll have to assess the tendon. So how do we confirm that there is a rupture? There will be signs of inflammation. Patient will be coming with pain, swelling. This can be at times subtle, may not be very obvious if there is a partial rupture, or just a stretching of it will constitute in grade 3 sprain. So if you have frank rupture, then the activity or that musculotendinous unit will be doing a patient will not be able to perform it. In case of trauma and all, where you have severance, where you have deep lacerations, cut, that kind of injury is there, you will have to obviously triage the patient, save the life and limb, and then function, which comes at the last. So only if the patient is hemodynamically stable, and accordingly you are going to assess the injury and see. So if every other thing is fine, patient is hemodynamically stable, it's a local injury, there's no systemic complications, there are no associated fractures. Even with fractures, if you're planning to fix the patient, you're going to do a primary repair. So basically, how to understand, it's about your clinical examination. Okay, very rarely, not in acute cases, we do MR. In rare degenerative cases, we do MRI to see the ischemia and the substance. So assessment by MRI is only done in the chronic cases. So for ideal tendon repair, you need to know this out of the topic. Probably this was the thing. So Strickland has given 6 criteria. So the tendon sutures should be able, you should be able to place it easily. Knot should be able to secure, and the tendon end should be smooth. There should not be any gapping at the repair site, and you should not be able to you should not be stripping the epitene. Okay, so the vascularity of the tendon is intact. That's how we preserve it, that which is going to heal the tendon. And you should be able to provide sufficient mechanical strength throughout the healing with your good suturing techniques, as well as splinting and preventing unnecessary stress at the repair site. So these are the different, I'm going to just show you pictures, different ways of repairing tendon. Excuse me. So you are going to use a non-absorbable monofilament or multifilament suture. Usually Dacron sutures or polypropylene sutures are used, basically, which can last for, the strength can last for more than 3 months. The suture should be able to retain 75% of its strength beyond 3 months. That is the criteria for choosing a suture. So if there is a spontaneous rupture, degenerative tendon, I told you already the pathology. So repair might not just be enough because the substance is weak. There is metabolic alteration. So you might need to substantiate your repair. That may you need to use a augmentary tendon. You need to augment your repair in that case. So these are different suture techniques. If you have avulsion, you are going to fix it with a from the bony attachment. Then there are various techniques. This is a button technique here, where you take the tendon through the suture and fix it through the button on the skin surface. Later, you just pull the suture off and cut it from here, and there is a fibroelastic tissue which is forming here at the bone and the tendon site. Or you can, if you're not able, length is not enough to take the tendon at the distal, to insert the tendon at its attachment, you can move the attachment of the tendon. You can drill a hole here and attach the tendon like this, so that you can maintain the function of the joint, basically. And here are some novel techniques. You have suture anchors, you have suture pins through which you can drill and attach the tendon. So these are basically used for the avulsion injuries where you don't have sufficient bony chips to reattach, or you have loss of the tendinous structure. So basically, if you go on to tendo Achilles, you can have post splintage is required post repair for 6 weeks initially, can be for longer time. You can have to use ankle foot orthosis for like around 6 months at times, depending on the strength you achieve post repair and by physiotherapy. So this will deal with hand injury. So these are the various techniques. There are innumerable type of techniques described here. This is a Krakow's technique. I have just put the pictures because this can be asked as a multiple choice question to you for your entrance purpose. Orthopedics, nobody is going to ask you tendon repair. This is a cold technique again. So here again, same principle is being used with a suture. You have a button on the skin and you have taken a zigzag suture and attach the tendon. These are bundles, Kessler's, Tajima, Bevel, various techniques are there. You just need to know the names and the configuration of the sutures. That's why I put up pictures. When you have degenerative thing where you have, so you use different techniques. This is the Lindholm technique. Basically, here you do an advancement. Basically, you detach a sleeve of the aponeurosis here and do a double breasting of your repair. You do a primary repair here and then do a double breasting of it. Here it is the plantaris augmentation. You have plantaris tendon, and you detach it from your its attachment, and you augment the reconstruction using plantaris tendon. And at times when you have a gap here, that can be filled by separate. You just cut the sleeve tendon in the smaller portion and repair in zigzag or the cross fashion. So you have peroneus brevis augmentation also, you have plantaris augmentation also. So which of the function can be spared in that age group according to the patient's need? And that tendon you need to harvest and augment it. You have certain artificial materials also. Just to list them, there are Dacron tapes, Nitrilon sutures, polyethylene tapes. You have polyethyl, ether ketone. These are the artificial materials which can be used at times. Not really. We just need use them for augmentation, mostly in revision ACL surgeries and PCL surgeries. Not much for tendon repair, because there you need constant force and constant working. So these materials obviously weaken over the time because they are not vascular. So they just provide a scaffold and they gradually weaken over time. So you need something natural, and these only can be used for bridging the gap or the synthetic part of it. Thank you. That's all.